Good afternoon. Welcome to Community Health Watch. I'm your host, Gail Lewis. So, your elderly mom or dad is on Medicare and unfortunately needs immediate medical attention. What do? You rush them to the local emergency room of your local hospital. What happens next can have not only health repercussions, but financial repercussions as well. Each year, the elderly are the largest consumers of health care in the United States. And additionally, each year, over 75,000 elderly persons nationally, unfortunately, die because of lack of good quality health care. So today, joining me here on Community Health Watch is Maria Alvarez to discuss patient rights and the elderly. Thanks for joining me, Maria.
Thank you so much for having me, Gail.
It's great to have you here. And you are Executive Director of the New York Statewide Senior Aging Council and also the Brooklyn-wide Interagency Council of the Aged.
Yes.
Oh my gosh, that's a mouthful.
Yes, it is.
And in that capacity, just tell us what you do.
Well, what we do in both organizations on a statewide level and in Brooklyn is we inform seniors of different issues that affect them. But actually, the seniors who are our membership decide and inform us what is going on in their lives, how different policies affect them, and they work toward improving their quality of lives through legislation, through social activity, through civic engagement.
Oh wow, that's a lot.
Yes,
yeah,
it is a lot.
And it encompasses a lot because there are many different parts of Medicare. There's many different, I guess, wheels that turn in healthcare.
Yes.
And just getting them to turn in your favor, if you're elderly and infirmed, seems like a lot to get through.
Yes. Well, I mean, the thing is that in terms of the elderly are the largest consumers, like you were saying, of health care in this country. They're in that health care, they have twice as more primary care and 5 times more acute care than the younger population.
So they're 5 times more likely to go to an emergency room
for an acute,
right?
Yeah,
okay, to have an acute or abnormality. Or,
right, exactly.
disease.
Which means that the cost then is going to be a lot larger for the senior population than the younger population.
So if a senior is taken to the emergency room, let's say, and I know I've been through this with my parents as well. Sometimes they are placed under observation, and sometimes they are admitted. And I'm not in healthcare. I don't know the difference, and I'm sure that if an elderly person goes to the hospital and they're already infirmed, they might not know the difference. So just spell out the difference for us between being admitted when you're taken to the hospital and instead being put under observation.
Right. Well, so when you're admitted, you are basically, what happens is Medicare Part A will pay for your stay.
So that's a good way to remember.
All of the, yes,
admitted
all of the
A. Okay.
Right, exactly. When
that
you are,
what?
that includes your hospital stay, anything that happens to you in the hospital, the doctor's visits in the hospital, medications, anything that happens in the hospital. But if you're in Part B, that's outpatient. So the patient might be responsible for co-payments for prescription drugs and for things like that, which not necessarily is bad because sometimes it is less expensive to pay as an outpatient for certain services than if you were an inpatient. Now the thing with observation status and what's happening in this situation is that many of the patients who'd previously gone to the hospital, they're used to being in the hospital, and being admitted to the hospital. They were in the bed, they were next to everybody else and being treated the same way. They assume that they're being admitted into the hospital, that they were
which I would think
admission.
is a logical assumption. You're in a hospital, in a bed,
right.
There's other people around you. You're assuming that you were in the admitted status.
Exactly. And then when you get home, you receive a bill that you're responsible for. And we don't know what the difference is, because you could even have had the same situation have been paid by Medicare many other times. So that was the confusion. And we have patients' rights helplines. You know, we have a helpline that we'll provide you with later on.
And that number is 1-800?
1-800-333-4374.
And you were getting calls in on that toll-free helpline?
Yes, we were getting calls from people saying exactly that. I was in the hospital, and all of a sudden, and I received this bill for $10,000, $30,000.
Oh, wow.
That I am responsible for. Why would that be? So after a little bit of digging and asking around, we found that because the Center for Medicare and Medicaid Services was determining that many hospitals were readmitting patients constantly, and it was causing a lot of larger costs, what they were trying to do was say, well, we want to make sure that the hospital has proper discharge planning. So if there is a patient that comes back within 30 days with the same condition, we are going to pay at a lower rate. We will reimburse the hospital at a lower rate as a penalty, basically.
Right. And they are penalizing the hospital because the patient should not have been discharged in the first place, or was discharged too early, or was discharged without proper orders?
Right. Well, what happens is that, and we hear it all the time, a patient might be discharged, and of course you want to get home. I mean, after being in the hospital, it's not pleasant. You want to be home in your surroundings.
That's really your focus at that point.
Exactly. However, there are certain realities. There are follow-up appointments, there's transportation, there's nutrition, they might need a nurse coming to their home to check up on them. And we've heard many times that a patient would say, well, I didn't have a way to get to my doctor's appointment, and then I got sick, and then I ended up back in the emergency room. You know, I didn't have meals, or my prescription drugs were not, I didn't have a way to get to the pharmacy, or they were not, you know. So all of those things contribute to a person not being able to thrive and to get better while they're back home.
And then that leads to another trip to the emergency room.
Exactly. So the hospitals, rather than be penalized, and we understand that rather than being penalized, they said, well, if we don't admit them in the first place, then there cannot be a penalty for them coming back 30 days, within 30 days, if they did, God forbid, with that same or a different condition. And so that's how hospital readmissions, which are not new, but they have skyrocketed in the last 5 years.
Why have they skyrocketed?
Well, because of this policy that they will be paid at a lower rate if there are avoidable readmissions.
Yes. So to avoid the penalty, they, instead of giving you the admitted status, they give you instead the observation status.
Exactly.
And if your mom is sitting in the hospital and she's come through the emergency room, are there any telltale signs that she's being under observation instead of being admitted?
Well, in New York State, we just passed a new law. And by law now, any patient, any Medicare beneficiary who is being placed under observation must be informed 24 hours, within 24 hours, verbally and in writing by the hospital staff. And what they will be told is that they are not admitted, they are being placed under observation. There may be a financial implication to that, and then they're advised to speak with their insurance company to make sure that they know what those issues are.
And that is to avoid that big financial burden once you get out of the hospital.
Well, it's really to make sure that they understand that there might be, that they're not being admitted to the hospital, and there might be an extra cost. But it also gives the patient and the caregiver, hopefully, the ability to assert their rights as a patient.
And to do what?
Because they may be able to appeal the fact that they're being placed under observation. They might be able to talk. You know, it's important to keep the primary care doctor whoever is there, informed of this. Many times their primary care doctor doesn't even know that they're in the hospital.
Right.
Because the primary care doctor really has a lot of that patient's history. If, like you were saying, if they're in an emergency, they end up in a hospital and nobody really knows what their medical history is, there might be a lot of other reasons why that patient is in the hospital rather than just one incident.
Right.
So the primary care doctor can actually speak to the admitting doctor and say, listen, it's not because, this person has hypertension, this person has, diabetes or something, an extenuating circumstance, they need to be admitted to the hospital rather than being, just placed under observation. So it's very important.
This law also calls for the inclusion of the primary care doctor.
No, it just very, very basically says that that to notify the patient and that the patient needs to speak to their insurance company to find out what the financial implications are. But what I'm saying is that information is power.
Yeah.
So the moment and so what I would suggest is that anybody who's being placed under observation should call our helpline.
Yeah, absolutely.
And then we could obviously advise them on how to proceed. But there might be other avenues for them to appeal to see if they could be, instead of be placed under observation, to be admitted. Now, of course, again, it's not in every case that we want that a person, that it would be beneficial for a person to be placed under observation, because sometimes as an outpatient you pay less for some of the services.
Yes.
So so it's not a 100% blanket action, but it's good to know. That information is very important to know, especially one case where it's usually important to know is if the patient knows that they're going to end up in a skilled nurse facility.
Right, and a skilled nurse facility, for people who don't know, is
a rehab center, let's say. Let's say you broke your, a hip or an arm, and you're going to need rehab services, and most likely you'll be transferred to a rehab center.
Right, so let's say you go into an emergency room, you've broken your hip, you're elderly, you're on Medicare, and then they do the best they can with you, and then they send you off to some place where you can get some rehab.
Right. So what happens is there is a law that says that a patient, and this is a federal law, that says that a patient needs to be admitted to the hospital for 3 days, for 2 midnights, 3 days, so that Medicare or the insurance company can pay for the cost of the rehab.
Okay.
So if the person is under observation, what happens is
not admitted
to the hospital, then the patient is responsible for that care.
Wow. So when you say for that care, you mean the care in the hospital, the care at the facility, or both?
It would be both.
Wow. Okay.
Yeah, or it could be part. In the hospital, it could be part because, if you have a Part B, some of your insurance pays for it.
But definitely that rehab facility.
Yes, Medicare would not cover, if you're not admitted in the hospital for 3 days, they would not cover the cost for the skilled nurse facility.
That's amazing.
Yes, it's horrible. And
let's say you're in that facility for 2 weeks, 3 weeks even.
Yes, they say that the statistics show that the average amount of observation status costs are $10,000 per patient, but we have gotten calls on our hotline where it's $30,000 or more.
And these are elderly people living on fixed incomes?
Absolutely.
Yeah.
And I just wanted to tell you that over in the 2012-2013 year, over 2,000 hospitals were penalized for preventable readmissions.
Right. And those are the readmissions within 30 days.
Right. And unfortunately, many of the hospitals that fall under this category are the ones that serve the poor. So poor communities are being impacted at a higher level.
So urban communities, communities.
Yes.
where there are a lot of elderly people or impoverished people.
Right, are being impacted at a higher level.
Wow.
Yeah.
So what can we do? If an elderly person is admitted or is taken to the hospital, let's use that broken hip example. Let's say after it, the current law is that you have to be admitted for 3 days.
Right.
Let's say 2 days have passed and the hospital wants to transfer you to another facility to start rehab. What can you do to ensure that you're not going to get penalized and have to pay for your rehabilitative care?
Right. The patient should, first of all, I mean, the best thing is to always speak to the staff, but if they're trying to discharge a patient, the patient has to have a signature. By law, you have to, the patient has to sign agreeing to be discharged.
Can you refuse?
They could refuse, and they should refuse if they are not, if they don't feel, either if they're going back into the community or if they're being transferred elsewhere, they could refuse that because they don't feel that they are ready. And obviously, if you want that one more day so that you can become admitted, that would be a way to do that.
Wow. So if you are, let's say, going to be discharged and you know that your home is in a rural area and you won't be able to get around or get to your other appointments, other doctor's appointments, follow-ups, you won't be able to get to your meds from the local pharmacy, you won't be able to have proper meals brought to your home, you can refuse to be discharged.
Until there is a proper discharge plan that you are satisfied with. You should not sign anything, any documents, because they cannot cannot take you, discharge you into the community. There has to be a consent from the patient.
That's huge.
That is huge, and I always advise the patients because, sometimes you want to get home, and
I'm thinking,
you're not focusing on,
You've been in the hospital for 2 days. You've been in a gown that exposes a lot of you.
Exactly.
It's uncomfortable.
And we all like to be in our comfortable surroundings that we know.
Right.
But we have to think, what is there that we need, what are we going to need in order to be able to stay home longer than wind up back in the hospital with something even worse, maybe?
Yeah, absolutely. And so to, I guess, kind of mitigate a lot of this, you've got your toll-free number, which is 1-800-333-4374. And those are great digits to put in your cell phone or to give to your mom or dad or for anyone who is a caretaker of someone on Medicare. On Medicaid care to have.
Yes, absolutely. Any, actually any senior, anybody who wants to call of a caregiver or a senior, we definitely will be able to assist them.
And I have here the Patient Rights Toolkit, which has got some really great stuff in it. We can get one of these how?
Those are available if you call our office, the 800 number, or if you go to our website, www.newyorknysenior.org, and you could download them also.
So you can just download this from nysenior.org.
Yes.
Or you can call that toll-free number.
And we would send them to a person free of charge.
And this is just chock full of great information, this Patient Rights Toolkit. The first thing that just gets me is that first brochure, which clearly says, take this brochure to the hospital. This is the sort of thing I think of my own parents, I think of other elderly people. First of all, I just love that it's written in big print that people who may need their glasses to read can read if you've forgotten your glasses at home.
Yes, we try to make everything easy to read.
Elder friendly, absolutely. And this is very clear. Take this to the hospital.
Yes, and put it on your nightstand. We always say put it on your nightstand, and maybe people will say, oh, that person knows something, so we have to,
absolutely.
to make sure
this helps to inform the patients. Take this brochure to the hospital. It lists important numbers in here. It also reminds you what you should take to the hospital with you. If you have to go in an emergency situation, what you should do when you're actually in the hospital, during your hospital stay, and then most importantly, appeals.
Right, appeals, and then after the words and the discharge plan, which is on the other side. Right. And as with anything, the best way to do anything is when we're prepared. So we always say have this beforehand, before we even need it is the best way to have it. So that way we're prepared. We could put everything together, all the documents together that we need, and and then that way once that situation may arise, then we're prepared.
Absolutely. And it also covers what to do when you are are discharged, when you
Right.
prepare home, and then of course what to do when you get back home as well.
Exactly.
That first brochure, and I'm thinking if I'm a person in the hospital and this is sitting right there next to me on the, next to the bed, that when people come in and they see this, they'll know that I at least have some information.
Exactly.
Information's on my side.
And that was the idea, right?
Absolutely. And in big red print too, we like that. There's other things also in this patient's toolkits. You've got personal
health record. That is a wonderful tool for especially the patient, but the patient's caregiver, because it has a large, we could put down our whole history of what medications are we taking, who our doctor is. When we go to the hospital, sometimes they'll start asking you, what type of medication are you on, who's your doctor, what appointments did you have. The best thing to do is to say, here, when I'm sick, I don't really know, I may not know the best things. So here, just show it. And
you can have more than one specialist, you can have more than one ailment, and this just kind of keeps it all together.
All together in one place.
And it's also great that it's something you can write in, because we have a lot of electronic apps. There's several apps to keep track of this information on your smartphone, but I'm thinking my mom's not going to populate the information on her smartphone because, well, it's a flip phone. And, and I'm sure, there are a lot of elderly people who share what my mom shares.
Exactly.
So that, something like this, just to have all of that information in one place, medication record, her personal information, also a medical history, and caregiver and hospital information.
That's very important.
In one place where you can just grab it and go.
Right.
Again, excellent. That's in the toolkit as well. Observation status, this is what we talked about.
Right, that's what
Observation
we talked about.
versus being admitted. And it just clearly kind of explains it in a way you can understand.
And it goes through the appeals process, which can be quite lengthy. Once you were in it, it could take there are 5 different levels of appeals.
Yes.
So so that explains it. It's not in depth, but it's a very good primer on what to do, and we give further information on how to.
And that's
get
another
the
thing I like.
resources.
If you need more help. The resources you can go to. Clearly, the addresses and the toll-free numbers where anyone can call for more information. Of course, your number as well. And medical records Q&A.
Yeah. We get so many questions, from people saying, well, I was supposed to get my medical records from one doctor to take to a specialist or to another. They're taking too long. How much can, they charged me an arm and a leg for it. Well, there are certain guidelines that the Department of Health has as to your medical records and accessing them. So we just basically took that information and put it on another brochure.
That seems like a great idea, because you always do have those questions about how can I get my medical records? I asked for them and I don't have them. Are they my property, or are they the property of the hospital, the property of the doctor, the property of the primary care physician? All these questions. So this kind of all breaks it all down into one place for you again. And again, more information, go to these places. We like that. Advanced directives for healthcare. Lots of questions about the 2010, the new laws that were enacted in New York State to allow your family or your friends to make decisions on your behalf.
Well, it's important because it's important that our wishes be carried out, whether we're able to make that, say them or not. So in the event that becomes the case, it's good to, number one, be able to know what we want and to be able to spell those out, but also to select the proper healthcare advocate. So we go through, what that person, an effective healthcare advocate should be, and then also beforehand, before you select it, make sure that you know what it takes.
Who's a good advocate for you? Is it your niece? Is it your next door neighbor?
Well, it's anybody who will be able to carry out your wishes, and that's easier said than done. I could tell you. Sometimes people might be emotionally involved and say, well, I don't think I could do certain things. I could do not resuscitate, or or maybe I can't say, well, if this person didn't want any heroic measures, but I feel bad about it, you know. So it has to be somebody that you know will be able to carry out your wishes, you know, to the best of their ability and to the letter of what you want, because that's your right as a patient.
Yeah, absolutely. And so this is very important. I think a lot of times just because it's difficult for us to talk about this, this generally means death, you know, or infirmment, or malady or something. So this is very difficult to talk about.
Right.
So just having everything in one place where we can just look at it and make decisions
and
is
it's
really
a good
important.
Conversation starter. You know, you could use this as a conversation starter. Many times we make presentations and we just go and, you know, we talk about it, and, you know, it sort of demystifies and takes away that you know, they say that once you share something, the light becomes, the load becomes a lot lighter.
Off.
Yeah, exactly. So talking about things is the best way to break things down.
And lastly, roles and responsibilities of an effective healthcare agent. Again, what we talked about. Who is the best person to pick?
Right, exactly. Who's the best person to pick? And then that way you see, because, you know, sometimes in families, you know, everybody wants to have a say.
Right.
But there has to be one person, and you know, that actually takes that lead. So so then that would be for the person to, you know, the patient to make that decision. And then we have a also the card. There should be a card in here. It's a great card because it has our number on the front.
And that number again, 1-800.
Right.
333-4374.
But then on the back, it has all of the important numbers to, you know, to the iPro, to appeal discharges, to the Department of Health. And this is a business card size that you could just put in your wallet and take with you. And it has a very special finish, so it's not gonna, you know, you could dunk it in water. You could.
It's not easily crushed.
Right. Exactly.
Wow, Maria Alvarez, Executive Director, New York Statewide Senior Action Council and Brooklyn-wide Interagency Council of the Aging. Thank you so much for sitting down today and talking about patient rights and the elderly. Closing thoughts?
Well, we welcome more of the seniors and caregivers and families to be involved in senior issues, and we have meetings every month. And
for more information, we can go to newyorksenior.org, and of course that toll-free number for help, questions, anything, 1-800-333-4374. Thanks, Maria Alvarez, for joining us here on Community Health Watch. Of course, for more information, email me, Gail Lewis, newday2010@yahoo.com. And of course, hit Maria up at www.newyorksenior.org. Thanks for joining me here today on Community Health Watch. It's been a pleasure with Maria Alvarez, and I hope to see you again here real soon.